So like Mike said, today we're going to be covering hematology and stem cell transplant-oriented chemotherapy. Our objectives for the day are going to review the class and indications for various oral chemotherapy agents. And I think that's really, whenever you're thinking about these drugs, your grounding basis and jumping off point for trying to remember all the other idiosyncrasies about these. So then we'll review also relevant adverse effects for each class and agent. And then by the end, you'll be able to delineate key interactions, dosing pearls, and administration pearls for the medications. So as an overview of where we're going to go today, we start off with the BCR-ABL inhibitors and CML. Then we move on to the CLL and lymphoma realm with BTK and PI3 kinase inhibitors. Venetoclax will bridge us between CLL and AML. And then in AML, we'll do FLT3 inhibition, IDH inhibition, and then at the end, we'll cover the retinoic acid derivative tretinoin, as well as JAK inhibitors and myeloproliferative neoplasms. So starting off with our BCR-ABL inhibitors, I've organized these slides so that they go by generation whenever they list the drugs. So our first gen agent is imatinib, our second gen agents are dasatinib, nilotinib, and bosutinib, and then our last gen was the ponatinib. So some of you may know Gleevec or imatinib is the blockbuster chemotherapy agent, cover of Time magazine, kind of ushered in the era of targeted therapy, and this is coming up 19 years ago now. And so really did start out this era and ushered in oral chemotherapy. So BCR-ABL inhibitors, this is a fusion protein of a translocation between chromosomes 9 and 22, leading to the Philadelphia chromosome, which leads to constitutively activated tyrosine kinase and uncontrolled cell growth. Most commonly associated with CML, but has been documented or does influence other malignancies, most notably ALL as well. So looking at our dosing considerations, and we'll move through this a little bit slowly, you can see first gen on the left, last gen on the right. Starting at our dosing, all agents are going to be once daily with the exception of nilotinib, that's twice daily. A general rule in chemotherapy is that most of them aren't going to require renal adjustment. I'd say 30 to 40% medications do. And so here that's imatinib, and so that's something that we're just going to have to check for agent specific for those patients who have chronic kidney disease. And then in hepatic metabolism, I would generally assume your oral chemotherapy agents are going to be hepatically metabolized by CYP3A4, and that's demonstrated here. For which agents require adjustments in cirrhosis, that's going to be more specific, and just you're probably going to have to look that one up. For metabolism, 3A4 metabolism across the board with our BCR-ABL inhibitors, which is typical for oral chemotherapy. The other thing to call out here, though, is how imatinib and nilotinib are not just substrates, but also inhibitors. So whenever we get those patients who might be on multiple antiarrhythmics or anti-epilepsy type drugs, we need to not only think about how those drugs will affect our oral chemotherapy, but also how our oral chemotherapy will affect the current med list. And so that's something that we need to consider with those agents. Finally, with this class, the food and acid interactions are something we always need to think about. So most agents are with food, with the exception of nilotinib, which is on an empty stomach, and can be challenging for some patients with its twice-a-day dosing regimens. Is something that we want to bring up and discuss with them whenever we're talking about starting the agent. And then the acid interaction can also be quite relevant. There's some recommendations in some of the package inserts that you can space out H2RAs by 10 hours due to data and other malignancies showing a decreased response in some of those patients. I prefer just to avoid them entirely where we can and try to stick to things like Tums separated by at least 2 hours. Additionally, because H2RAs and PPIs are both over the counter, this is something that we always need to be kind of screening for and making sure patients are aware of. So something that can definitely affect therapy. Moving on to more class toxicity type effects, bone marrow suppression can occur across the board with these agents, as well as rash. And then agents have different off-target effects as well, leading to a distinct side effect profile. So starting on the left, with imatinib, fluid retention is one of the big warnings with this one, notably periorbital edema So something to make patients aware of and be watching out for in addition to nausea, rash, musculoskeletal pain. With dasatinib, we also have fluid retention, but more pleural and pericardial effusions that we're thinking about, as well as pulmonary arterial hypertension and platelet inhibition. Nilotinib, our big monitoring point is going to be the QTC prolongation. So baseline EKG as well as EKGs weekly after initiation until we can ensure they're stable, as well as some metabolic effects in pancreatitis. Bosutinib can cause diarrhea and hepatic toxicity as well as having fluid retention. So those are the things we need to watch for there. And then ponatinib is reserved for only patients where no other agent would really have efficacy because of its various black box warnings and the severe toxicity that can be associated with that agent. And so those include ischemic reactions like heart attack and stroke, vascular occlusion, and then pancreatitis, hypertension, and hepatic toxicity. One of the really cool things about this class of agents is it's one of the few places that we really have good data on the effect of adherence to oral chemotherapy and outcome of a malignancy. So in oncologic diseases, we generally assume we have higher adherence rates just because the hazard linked to cancer. However, this doesn't necessarily play out in the data. And so poor adherence is identified as one of the most important factors contributing to relapse and failure. And so the Adagio study was able to evaluate this, where not surprisingly, non-adherence or poor adherence was associated with poorer response to therapy. The one number that sticks out in my mind is that 85%, where less than 85% adherence had a significantly higher probability of losing their complete response at 2 years than those with a better adherence rate. This is one of the only independent predictors for achieving a complete molecular response, and lower adherence is associated with younger patient age, adverse effects, dose escalation, as well as higher copays. And whenever we think of 85% adherence, that equates to about 4 missed doses per month. So if someone's missing a dose weekly, that can make them statistically more likely to fail therapy. So something that we have great data for that I always broach in my patient counseling for these agents and really for all chemotherapy. So that brings us to an assessment question. So QR is this 27-year-old male starting nilotinib as first-line therapy for CML. He is noted to have a suboptimal response to therapy on BCR-ABL testing. Which of the following could contribute to a suboptimal response? Could it be A, concomitant carbamazepine use, B, lansoprazole as needed for heartburn, C, occasionally missing an evening dose, or D, taking with food, or E, all of the above? And if you guys would just type in the chat function if anybody has any guesses about what they think the answer is, and we'll give that about 10 seconds, or else maybe I'll call on somebody. So it sounds like no takers on that one. So Jeremy is one of the more experienced fellows, or sorry, Dr. Krantz is one of the more experienced fellows here. Do you have any guesses about what you think this could be? Okay, so I was once counseled that if no one responds, it means the question's either too easy or too hard. So we can break it down a little bit and go from there, though. So A, concomitant carbamazepine use, because that's an inducer, that would reduce our nilotinib exposure. So that could decrease our response. Our nilotinib is a second-gen inhibitors, and those all require an acidic environment for absorption, so lansoprazole could reduce our exposure. Adherence, of course, is important with any of these agents, so missing evening doses could also contribute. And then nilotinib is our one inhibitor that's required or recommended to be taken with food. So taking on an empty stomach could potentially lead to increased toxicity as well as a suboptimal response. So the answer is E, all of the above. So a lot of the different pieces that we need to be thinking about with toxicity can need to be evaluated with suboptimal response. Moving on to our next category of agents then, is Bruton tyrosine kinase inhibitors, or BTK inhibitors, where our first-gen agent is ibrutinib, and then our second-gen agents are acalabrutinib and zanubrutinib. So BTK is an integral to B-cell receptor signaling, which is constitutively active in many B-cell malignancies, and so inhibition of that receptor leads to cell death and inhibition of cell migration and proliferation. Looking at our different inhibitors on the right, we can see they vary in selectivity for the BTK inhibitor, and then ibrutinib, being our first generation agent, also has off-target effects on EGFR, ITK, TEC, and BMX. So looking broadly at our FDA-approved indications, and I do go back to the FDA indications a lot because from the perspective of what you can actually get patients the drug and what you can get paid for, a lot of times that's guided by the FDA indication. And so ibrutinib, being our first approved agent, has the most different indications then, with CLL, mantle cell, marginal zone, Waldenstrom's, and second line in graft versus host disease, chronic after steroids. Acalabrutinib is approved in both CLL and second line therapy in mantle cell lymphoma. And then zanubrutinib is approved in second line therapy in mantle cell lymphoma. So looking at our dosing considerations for these agents then, they are either once or twice daily, with zanubrutinib actually having both in the package labeling. In my experience, we've used it once daily just for ease of patient dosing. None of these agents require renal dose adjustments. Some require hepatic adjustments in cirrhosis. And all are 3A4 hepatically metabolized, which can be relevant whenever we think about the toxicity profile of these, with some agents causing AFib, and moderate inhibitors like diltiazem and verapamil as non-dihydropyridine calcium channel blockers causing 3A4 inhibition. So those are some of the two more common agents that I've seen whenever it comes to drug interaction screens with these agents. Additionally, acalabrutinib does have similar acid interactions to what we see with the BCR-ABL inhibitors. So that is something that we need to be watching out for, that medication as well, if someone does have a history of GI bleeding or something like that. Looking at our toxicity profiles then, you can see we have some class toxicities, but they seem to be more common in the ibrutinib. So atrial fibrillation and bleeding at 5% with ibrutinib. Zanubrutinib generally has been thought to be less toxic in terms of causing those. However, these are just based off the package insert, and you can see that doesn't necessarily play out. So that's something that we'll have to continue to follow. And then acalabrutinib, while being thought to have less atrial fibrillation than ibrutinib, I don't think I would quite say that it has none. So I still would list it as a potential side effect of the medication. And then the additional aspect of those effects is thought to be that TEC kinase inhibition of ibrutinib. The other point with bleeding is that this is thought to be mediated by platelet inhibition. So something that we want to, from a drug interaction perspective, we need to really think about anybody who's on things like aspirin or Plavix on these agents, because there will be additive toxicity from those bleeding events. Other common side effects in patients include diarrhea and rash. Once again, more common with our ibrutinib, likely due to its EGFR inhibition. However, it is noted in the two other agents as well, with acalabrutinib and zanubrutinib. The unique toxicity to acalabrutinib is going to be its headache, coming in at 40% of patients. Typically, we just want to be treating that with Tylenol, trying to avoid our NSAIDs, once again, due to the bleeding risk. Moving on to the PI3 kinase inhibitors, duvelisib, idelalisib, copanlisib, and alpelisib. So phosphatidylinositol 3 kinase pathway, or PI3, AKT, and mTOR signaling pathway, affects a variety of cellular functions throughout the body. And I really like this diagram at the right-hand side that shows you the different receptors, or the different medications in terms of what subtype of receptor they hit. Alpha notably has a role in insulin signaling, which will influence our adverse effect profile. And then the delta receptor is preferentially expressed on leukocytes. And so not surprisingly, a lot of our hematologic active agents hit on that receptor. Looking at indications and formulation, idelalisib is licensed in CLL and follicular lymphoma, as is duvelisib. Copanlisib is only in follicular lymphoma. And then we have apelisib, which is the only solid tumor agent from the day that's licensed in advanced breast cancer. And I think that really underscores how widely these medications are being evaluated for use in all different sorts of malignancies. In terms of formulations, copanlisib is the only IV drug from the day that's given IV once weekly, and the other three agents are given by mouth once or twice daily. From a dosing consideration standpoint, they are somewhat similar in that all hepatically metabolized by 3A4, susceptible to those relevant drug interactions, and no agents require a renal dose modification. Moving on to the toxicity profile of these, and this is what I think is really limited or makes it a challenge to implicate or to include these in clinical practice. There is a clear immune activation component to these agents, and so the first four categories then are going to be class toxicities for these. Looking at diarrhea, that has a bimodal distribution, where the first month or two, you see more of a chemical type diarrhea, not unlike what you might see with ibrutinib. But 3 to 6 months down the road, you can see an immune activated colitis that's more severe, and you might think of it more similar to an immune checkpoint inhibitor toxicity than what we would normally think about with TKIs and oral chemotherapy. So that's a major monitoring point. Similarly, we have immune activation, so rash and pneumonitis have been documented. And then we can see liver toxicity and ALT elevation with all of these. And once again, because that immune activated component, these can all appear 1 to 6 months after starting therapy. Moving into unique agent toxicities, hypertension associated with copanlisib. Because this hasn't been seen with the other agents, I suspect it's more associated with its dosing as a once weekly rather than a continuous dosing oral schedule. But you can see grade 3 adverse effect in about a third of patients, so something we do need to manage clinically. Similarly, the hyperglycemia is something that we see with any of our alpha active receptors with copanlisib and apelisib. And so once again, hyperglycemia is not an easy side effect to manage in terms of in the oncology clinic, just because we aren't that equipped to, or used to handling it. And grade 3 occurring in about 40% of patients does require significant management. And then for our hematologic agents, all of these require PKP prophylaxis due to some documented cases with this. So there is some sort of immune suppression occurring as well with them. That brings us to our BCL2 inhibitor, venetoclax, as we move between CLL and AML. So venetoclax inhibits BCL2, which is an anti-apoptotic protein. So we're inhibiting an anti-apoptotic protein, which induces cell death. And it's indicated in both CLL and AML. Looking at our dosing schedules, these are going to vary greatly according to the indication it's being used for. All doses should be administered with food, and then venetoclax is highly susceptible to 3A4 interactions. So some things like carvedilol that we don't think of as being huge interaction meds actually do come up positive in an interaction screen, though we could probably debate about how clinically relevant that is. But the CLL dosing schedule is over a 5-week ramp up due to the higher risk of TLS in that disease state. The one thing that makes this much easier is the dosing pack that you can see in your top right. So despite how complicated this dosing schedule is, I haven't encountered as many challenges with it because that dose pack does make it pretty intuitive for patients to use. Though the challenge of that is if a patient does require to hold or decrease a dose due to toxicity, it can it can be a hurdle just in terms of how to get the patient the appropriate tablet size. On the opposite side, in AML, we have a 3-day dose ramp up, so 100, 200, and then 400 milligrams, which we stop at if the patient's on a hypomethylating agent, or 600 milligrams if we're doing low dose Ara-C instead, and then that is continual daily. And then there is some adjustments of that based on what our preferred antifungal therapy is in that patient and when that's approved and initiated. So looking at venetoclax adverse effects, Dr. Fletcher described venetoclax as being a cytotoxic agent because of its bone marrow suppression, which you can see is significant in both disease states. So in CLL, this is an agent I automatically submit for like growth factor 4 because that is something that we commonly need for these patients. Not surprisingly, the febrile neutropenia risk is very high in AML due to the disease state itself. And then thrombocytopenia is significant in both disease states. From a patient counseling standpoint, with what they can expect or might see during treatment, diarrhea is the most common side effect we encounter, though we typically can be managed with over-the-counter antidiarrheals. And then the hyperuricemia risk, mainly documented in CLL, though it can occur in AML. Diving a little more into that with tumor lysis syndrome prevention and monitoring, like I said, mainly concerned in CLL, requiring that extensive dose ramp up. All patients should be started on allopurinol at least 3 days prior to venetoclax initiation. I just had an AML patient who we thought was lower risk last week, so we didn't start her on allopurinol. She actually did develop TLS, so I think that across the board we should really be using that agent. And then you can see how complicated the lab monitoring is here, where for the first few escalations outpatient for low-risk patients, you need 3 labs, the baseline, the 6 to 8 hours post-dose, the 24 hours post-dose, and then you're doing that every week. It's actually a little easier whenever someone's in the hospital to get the Q4-hour labs after the first administration, but then for later escalations, they do still recommend all those different lab values. So this is quite intensive from a coordination standpoint. For time's sake, I'll skip over this, but this is really just a patient example of demonstrating that with an AML patient where you're looking at an antifungal, a decitabine initiation, venetoclax initiation, lab monitoring. So about 3 or 4 different real balls you have in the air and trying to figure out how you can respond to those labs in time if someone does turn out to be lysing. And this is something that as a fellow, we've had a few people get called after hours whenever these labs come back a little late and maybe we're worried about a patient or something like that. Moving on to pure AML indications then with our FLT3 inhibitors, midostaurin, gilteritinib. Sorafenib also has FLT3 activity, though we won't discuss it here. So FLT3 is FMS-like tyrosine kinase, which serves an important role in hematopoietic survival and proliferation. There's 2 different flavors of the mutation, internal tandem duplication or ITD, as well as tyrosine kinase domain mutation or TKD. And so the first generation inhibitors are agents that were really developed in other malignancies, and then on throughput screening were found to inhibit FLT3. So these tend to be broader inhibitors that also have other activity against things like VEGFR. The second gen inhibitors then were developed solely to inhibit FLT3 and tend to be much more potent and selective for that mutation. Separately from the generation, there's also type 1 versus type 2 inhibitors, where type 1 inhibitors inhibit both types of that mutation, ITD and TKD, whereas type 2 inhibitors are not effective against the TKD subtype. And this distinction might be more important as we have more agents coming to market. So in our 2 agents that we have on the market now, midostaurin and gilteritinib, these are very different in terms of how they're used and kind of what we see from them. So midostaurin is something that's used during in newly diagnosed AML during induction and consolidation, in addition to approvals in mast cell leukemia and systemic mastocytosis. It's only given during 14 days of each of those, so kind of quicker burst. Both agents do have the standard 3A4 metabolism with drug interaction concerns, which once again are important in AML with our antifungal therapies. In terms of adverse effects for midostaurin, nausea is really important. And so it's to the point that we pre-medicate patients with ondansetron. And diarrhea is noted, as well as a warning for pneumonitis. And then both agents have QTc prolongation potentials. Gilteritinib, on the other hand, is for relapsed or refractory disease. It's dosed daily, so continual therapy, likely because it's better tolerated, that we're able to give it that way. Lower incidence of diarrhea and nausea, so transaminitis and pancreatitis are kind of more unique toxicities for that one. Moving on to our IDH inhibitors, enasidenib and ivosidenib. So IDH then is isocitrate dehydrogenase. So whenever this receptor is mutated, it allows leukemic blasts to accumulate, and it's an anti-differentiation agent. There's two different isoforms of this, though they still result in the same end product, which is that accumulation of undifferentiated blasts. And so whereas with our FLT3 inhibitors, we thought of them as being very different, these two are very similar. So ivosidenib does have an additional approval for newly diagnosed AML. Enasidenib is really only approved in relapsed or refractory. So I think if we had a new patient, we could consider it there. Both hepatically metabolized. From an adverse reaction standpoint, we can see nausea, diarrhea, differentiation syndrome is going to be our big class call out. And then elevated bilirubin is the one that's pretty unique, along with hepatotoxicity to enasidenib that does have package insert recommendations for dose modifications. Both agents can prolong the QTc as well. So differentiation syndrome occurs due to rapid proliferation and differentiation of myeloid cells. These are the numbers for enasidenib, can include dyspnea, pulmonary infiltrates, weight gain, renal failure, as well as fevers. The onset for these agents is a little bit later, so 10 days to 5 months with a median of about a month. And then treatment is with dexamethasone 10 milligrams every 12 hours. Leading to our other differentiation agent of tretinoin. And so this is used in APML, given twice daily. Notably, it's only available in 10 milligram caps. So if we have a 2 meter squared BSA patient, they are taking about 10 caps per day, so sizable pill burden. Hepatic metabolism with no adjustments for renal dysfunction. And so the unique thing about this agent's differentiation syndrome is that it's a lot earlier than what we think for our IDH inhibitors. So it can be as soon as an hour, but usually within a few days rather than that like 1 month time frame. Also, the metabolic effects are significant with hypertriglyceridemia, and so that may require pharmacologic therapy and something we need to monitor in these patients, in addition to LFT abnormalities. Toxicities of this agent can be really tough to deal with just because there aren't any me-too drugs that we can kind of sub in. So though they don't occur in everybody, it can be very challenging when they do present. Finally, that leads us to our JAK inhibitors with ruxolitinib. This is a JAK1 and 2 inhibitor that inhibits cytokine production and is therefore used in myelofibrosis and polycythemia vera, as well as steroid refractory acute graft versus host disease, which we just had our phase 3 study published a few months ago. And so a lot of excitement, really, especially about the graft versus host indication in ruxolitinib, because we have seen some really great patient responses from that. In terms of toxicity, the chief one that we see is really going to be bone marrow suppression, which you can see across the board here. Thrombocytopenia especially can be challenging to deal with in myelofibrosis. And then just keeping in mind, this is an immune suppressive agent, so it definitely does make patients more susceptible to infections. Fedratinib is our highly selective JAK2 inhibitor given once daily. And the one call out for side effects with this is the Wernicke's encephalopathy, which really delayed its time to market. And so we really need to be monitoring thiamine prior to initiation and repleting if needed because of that side effect. Otherwise, generally well tolerated with more nausea and diarrhea, though, than we see with the ruxolitinib. So kind of bringing everything together, whenever you're thinking about these agents, I'd try to remember the class and mechanism to set the baseline for what to expect for toxicity as well as dosing guidelines with these. Generally, I would assume all agents are metabolized by 3A4. Definitely lean on your pharmacist for help with that. In addition, if patients do have renal or hepatic dysfunction, really you're going to have to check the dosing specific guidelines for each agent because those are a little tougher to use heuristics for. Thanks for your time. I'll pass it off to JJ then.
All right, can you guys see my screen and my slides?
Yes.
I think you're all muted. What's that?
Yes, we can see them.
All right, do you have it in presentation mode or no?
Yeah, it's in presentation mode right now.
Well, let's try and fix that. How's that?
Looks good.
All right, perfect. I get monoclonal antibodies. Our objectives are to review the history and basics, but frankly, that's been eliminated from the slide deck for time purposes. We're going to identify targets and mechanisms of various monoclonal antibodies. I cannot make my slides more colorful. I'm very sorry about that. And discuss some target-based toxicities of various monoclonal antibodies as well. There are several graphics that are very colorful, so hopefully that is a little more pleasing to the eye. Monoclonal antibodies, looking at evolutions of research used back in the 70s and 80s as flags in research labs, now being transitioned more as pharmaceutical agents and have been in use for, at this point, decades, which is very nice. Here's kind of the standard structure of a monoclonal antibody using a variable and a constant region. So you have these kind of constant anchors, and you have the variable regions that can be modified to target various antigens. You have the light and the heavy chains as well as part of these structures, the heavy and the lights. And again, we have these determining regions that can be used to target various antigens for therapeutic reasons, for targeting reasons. We have different kind of utilization of these monoclonal antibodies. We're going to be using their targeted purposes for therapeutic purposes. We have several highly effective tumoricidal functions. These monoclonal antibodies can be used to antagonize various receptors to try and block signaling or to just turn off a receptor in kind of a neutral manner. We have signaling where you can actually trigger a signal from a receptor leading to some sort of downstream cascade. You can have complement-mediated cytotoxicity where these monoclonal antibodies will bind to a receptor, triggering complement leading to cytotoxicity via complement. Or you can have antibody-dependent cell-mediated cytotoxicity where these monoclonal antibodies will target a receptor, recruit T cells, activated T cells, leading to cell lysis and cell death. A lot of these monoclonal antibodies will have a mix of various manners by which they lead to cell death, and I'll try and call those out on the slides. Kind of as a history, looking at these monoclonal antibodies and their nomenclature, we have these proteins that aren't 100% human-based proteins. A lot of the older monoclonal antibodies will still have quite a bit of chimeric or non-human proteins. In the case of rituximab, uses a lot of murine proteins, but the less human protein you have within these monoclonal antibodies, the more likely your body is to potentially reject or have a reaction to those proteins. So with the old classical example of rituximab, we know that a significant rate of infusion-related reactions is tied to this agent because of, at least in part, those non-human proteins that are associated. And as you work your way down the category to more human-based proteins, these monoclonal antibodies, these proteins are better tolerated from an infusion perspective. And then there's just a nice hint about the nomenclature and how we name these agents based upon their protein configurations. Starting with the old classic, CD20 targeted agents, rituximab is the old classic, or Rituxan's the brand name, but we do have two other agents, obinutuzumab or Gezvaya, and then the ofatumumab, which is a non-formulary product here at UW, but is used occasionally, Arzera, which is actually being researched in multiple sclerosis currently. These agents bind against CD20 on B lymphocytes. They activate complement-dependent and antibody-dependent B-cell cytotoxicity, but they also recruit neutrophils and produce free oxygen radicals, leading to cell death as well. They do lead to B-cell depletion for long-term. In Rituxan, it's 6 to 9 months, so it's a very long process. The difference in these agents, number one, you can see that they're based upon the nomenclature, you have less and less non-human protein within these agents as you get from Rituxan to obinutuzumab to ofatumumab. But in obinutuzumab, it binds to a receptor on the CD20 receptor that is very close to Rituxan, but it does lead to greater antibody-dependent cellular toxicity and is more effective for B-cell apoptosis than Rituxan, whereas ofatumumab binds to a distinct center within the CD20 receptor, not overlapping with Rituxan, and leading to greater B-cell apoptosis. So you have difficulty with Rituxan. These agents may have efficacy in those patients who are refractory to Rituxan. Indications, Rituxan has CLL, non-Hodgkin's lymphoma, RA, but many, many, many off-label indications. And you can see obinutuzumab and ofatumumab's FDA-labeled indications there as well. I've included the standard dosing for these agents. Rituxan is commonly 375 milligrams per meter squared every week or every 28 days, really dependent upon the regimen that we're talking about. Good to note here that at UW, we dose band our monoclonal antibodies, aka we try to round them if they're within a certain parameter. So these doses that you're administering may not be perfectly 375 milligrams per meter squared, and that logic follows through for most of our monoclonal antibodies. CD20 toxicities that are associated with these agents. We talked about infusion reactions, particularly with Rituxan, but you certainly can see them with the other two products as well. You can have severe mucocutaneous reactions, hepatitis B reactivation, which is why we check Hep B serologies prior to administering CD20 products. Progressive multifocal leukoencephalopathy has also been shown to happen with these agents. You can see nausea, vomiting, dizziness, headache, pruritus, and especially infusion-related reactions. Their emetogenicity is very minimal, but we do give pre-medication with Tylenol and Benadryl to try and minimize those infusion-related reactions. Drug interactions, you're going to hear this a lot during this slide deck, but we're really worried about immunosuppressants and live vaccines. Remember, you're depleting the B cells within these patients on a long-term basis. Quickly moving on to HER2 products, again, another set of agents that have been around for a very long time. I'd be remiss without mentioning on the CD20 products that since they've been around for so long, we are now starting to get into things like biosimilars, not necessarily generics, but different formulations by different manufacturers that may be equivalent, however you'd like to define that, or how the FDA has defined semi-equivalent. These agents are generally found to be equally as efficacious and potentially cheaper. So it's really nice to see the costs of these agents hopefully going down, particularly because Rituxan is one of the largest by dollar spends in the US on any pharmacologic agent. So it's nice to have alternative options that may make this and may make healthcare a little more efficient. Regarding the HER2 products, pertuzumab and trastuzumab we'll start with. They bind to the extracellular domain of HER2. They mediate antibody-dependent cytotoxicity. They inhibit proliferation of cells which overexpress HER2. And pertuzumab and trastuzumab may be administered in any order, but they should be given prior to docetaxel when that regimen calls for it. The brand names, in case you're interested, are Perjeta and Herceptin. These agents do bind, as you can see in the depiction, they bind to different subdomains of the HER2 receptor, and they have found to be synergistic for HER2-positive breast cancer. There are some new co-formulations of these two monoclonal antibodies, not something that's on formulary here at UW, but the more we work with these monoclonal antibodies, the more we're going to find more efficient ways to use them. And you're going to hear quite a bit about that when we get into things like daratumumab and things like that. Some indications for HER2-targeted therapies, obviously HER2-positive breast cancer, as well as HER2-positive gastric cancer. Trastuzumab holds an FDA-labeled indication for that. I've included the dosing schema on the slide kind of for your reference, and there isn't any hepatic or renal dose adjustments, though you do need to ensure that you are monitoring cardiac function judiciously, as there is a black box warning for cardiotoxicity for both of these agents. Teratogenicity also is a black box warning. There's an infusion-related reaction black box warning for trastuzumab, and pulmonary toxicity can be found with trastuzumab as well. Particularly GI toxicity with the combination agents is more problematic for these patients than single agent alone, but fatigue and rash can be seen with these patients and can be somewhat problematic. But these agents really have kind of revolutionized HER2-positive breast cancer management, and they really were kind of the forebears for the next two agents that we're going to talk about. Atotrastuzumab emtansine, brand name is Kadcyla. This is the first antibody-drug conjugate, I believe, that made it to the market. Here in the picture, you can see that you have kind of a HER2-positive trastuzumab monoclonal antibody. You have a linker from that monoclonal antibody to DM1, which is emtansine. Emtansine is a microtubule inhibitor that basically serves as a chemotherapeutic agent to a monoclonal antibody. And what you have is you have this HER2-positive monoclonal antibody that seeks out HER2-positive cells. They're internalized by those malignant cells. You have the breakdown of this linker, and then you have direct delivery of a chemotherapeutic agent to a HER2-positive cell. So you kind of have like a Trojan horse scenario regarding your chemotherapy to targeted cells. So it's kind of like that next evolution of delivery of chemotherapy. Dosing's on the slide here, 2.6 milligrams per kilo IV every 21 days. This is indicated in HER2-positive disease, residual disease, or metastatic disease after the use of standard trastuzumab. We do have black box warnings here for severe hepatotoxicity, which is kind of led directly from that microtubule inhibitor DM1. And we do have some other adverse events. We have kind of the trastuzumab-related adverse events, you know, those cardiotoxicities and things like that. But we also have anemia and thrombocytopenia, more standard toxicities associated with what you would think to be more standard chemotherapy delivery. Another HER2 plus agent, trastuzumab deruxtecan. This is an agent called Enhertu as a brand name. This is a relatively recent FDA approval, again, monoclonal antibody of HER2 trastuzumab with a drug linker leading to a topoisomerase 1 inhibitor. This is, again, a monoclonal antibody linker to a chemotherapeutic agent. Dosing is on the slide there. Its only indication currently is HER2-positive metastatic disease after two previous HER2 agents, aka after trastuzumab and after Kadcyla. Black box warning for interstitial lung disease, kind of the first presentation of that out of the HER2 products. Again, you have more of those standard chemotherapy toxicities of anemia and thrombocytopenia, but this is a monoclonal antibody that does have a significant nausea and vomiting risk requiring antiemetic premedication. Moving on to the EGFR products, we have cetuximab and panitumumab. Brand names are Erbitux and Vectibix. These products bind to EGFR, or endothelial growth factor receptor. Competitively inhibits the binding of endothelial growth factor and other ligands. It leads to the blocking of the phosphorylation and activation of these cytokines. So this is a good example of these monoclonal antibodies trying to block off those cell signals. And these signal transduction results are only really found in RAS wild type activation. So you need to use these in EGFR positive disease that is RAS wild type, whereas mutant cells are unaffected by these monoclonal antibodies. Indications, colorectal cancer, they both have a approval for that, but cetuximab has approvals in head and neck as well as squamous cell. The dosing is included on the slides. Cetuximab is 400 milligrams per meter squared as a loading dose, and then a weekly 250 per meter squared, whereas panitumumab has kind of a more patient-friendly every 14 days dosing adjustments. And we do have significant dosing considerations for pulmonary toxicities as well as rash. And as we talk about rash, here's a really classical example of an EGFR inhibitor-induced rash, kind of acneiform, significant, but also significant from a patient's perspective. They certainly don't like this rash. They don't want to walk around with it on. It can actually cause, and has been shown to cause, significant depression in these patients. So it's certainly something to care about. The black box warnings, we have infusion-related reactions as well as cardiopulmonary arrest. Here's a good example of the difference between a chimeric monoclonal protein and a humanized monoclonal protein, whereas cetuximab has a significant concern for infusion-related reactions. You can see 2 patients, or 2% of grade 3-4 infusion-related reactions in this study down below, versus less than 0.5% of patients for panitumumab have kind of a significant, whereas panitumumab lacks these significant infusion-related reactions because it has a more humanized protein. Panitumumab actually has a stronger affinity for the EGFR receptor, so you do see some more potency potentially with this agent. It is a little better tolerated, at least from this infusion-related reaction aspect, but it does have a little more skin toxicity to it. And they've really found that in this ASPECT trial, comparing panitumumab to cetuximab, a great trial because you very rarely see a head-to-head agent trial comparison, particularly for relatively expensive agents. But you find non-inferiority to panitumumab with potentially some better tolerability. This rash, going back to the rash, can be quite significant. We do like to see, at least in our colorectal patients, the patients on prophylactic doxycycline to try and prevent this rash. And we have a significant kind of build out of what to do with these rashes if they occur in our chemotherapy side. And we do have a GI pharmacist downstairs who's more than willing to help you out if these things develop. Moving to VEGF inhibitors, we've got kind of 3 big ones, but really it's dominated by bevacizumab or Avastin. We have ramucirumab or Cyramza, and then my favorite to say, zivaflivercept, which is the brand name of Zaltrap. Bev binds to and neutralizes VEGF, whereas RAM and zivaflivercept bind to the receptors, and they can act as decoys to these receptors. So they act in a functionally slightly different manner, but they all lead to the prevention of VEGF binding and endothelial receptors and triggering the inhibition of proliferation, angiogenesis, and microvascular growth. We do have a lot of TKIs as well with VEGF activity, and even some of these under investigations have been approved and are currently being utilized in practice. Lots and lots and lots of indications, mostly because if you can starve off the tumor of its blood flow, you can certainly get some lovely outcomes. So these are used in quite a lot of diseases. I've included the dosing here on the slide just to be complete. The biggest concern regarding VEGF inhibition is we're really affecting kind of all of these functions here. We're affecting blood pressure and increasing blood pressure. We're decreasing kidney function. We're looking at the coagulation cascade and angiogenesis and homeostasis and marrow functions. We have a lot of different effects from VEGF that, if you inhibit it, can lead to problems. We have black box warnings for GI perforation, so these agents should not be given around procedures up to 28 days out from procedures. We have lots of concern for severe or fatal hemorrhage because you are affecting kind of these angiogenesis and the microvascular spaces. And you also have issues with wound dehiscence. So again, with procedures and things like that, you need to be very cautious. These agents, as we mentioned, can lead to significant hypertension and blood clots, as well as GI toxicity. So we have a lot of considerations for these agents and their potential use with our patients, and whether or not certain patients are good candidates for them. Moving on from VEGF, we're going to kind of get into a potpourri of various agents that target various receptors. We've been kind of focusing on classes. Now we're going to get into a potpourri of targets. CD30, which is seen classically in Hodgkin's lymphoma. We have brentuximab vedotin, or Adcetris, another classical example of an antibody-drug conjugate, where you have a monoclonal antibody targeting CD30. We have a cleavable linker, and then we have a chemotherapy agent, or MMAE, which is a microtubule disrupting agent. Again, these cells bind to CD30 positive cells. They're internalized into those cells. They release their chemotherapeutic agent, and that, in this case, leads to cell cycle arrest in the G2 or M phase and disease apoptosis. Indications currently for brentuximab vedotin, so anaplastic large cell lymphoma. Hodgkin's lymphoma classically was used in kind of the relapse refractory setting. We now actually have an indication for previously untreated Hodgkin's lymphoma, coming from a nice paper of ABVD versus brentuximab plus AVD. So that's currently an option for frontline Hodgkin's. We have its approval after auto stem cell transplantation. And then we also have CD30 positive mucosis fungoides or peripheral T-cell lymphoma. So it's expanding its FDA approved indication. Dosing, again, included here on the slide kind of for your reference when you have some time. We have kind of some PKs information in case you're interested. The chemo agent, importantly, does hang around for several days post-infusion. We have black box warnings for progressive multifocal leukoencephalopathy. And we have some neuropathy considerations, which are new with this agent, as well as the nausea, vomiting, and anemia and thrombocytopenia that's more classically seen with these chemo antibody conjugates. We have some drug interaction considerations, again, adding in strong 3A4 inhibitors associated with the metabolism of MMAE, the chemotherapeutic agent. Next is a very interesting example, CD33 targeting gemtuzumab ozogamycin. Brand name is Mylotarg. Again, another antibody drug conjugate targeting CD33 with a cytotoxic kalikiamycin derivative, binding to CD33, internalizing it, releasing that kalikiamycin, leading to DNA binding, double-stranding breaks, and cell cycle arrest and apoptosis. I mentioned that this is a very interesting case because this drug was actually approved way back in 2000. They found in a 2004 paper that it was potentially increasing mortality in one of the trials. In fact, it was, I believe, 3-fold higher mortality in the Mylotarg patient population. There was a 2008 NEJM article really lambasting the FDA for not following up on post-approval surveillance data of this agent. The drug was removed from market by the manufacturer in 2010, and then it was reapproved by the FDA back in 2017. So it's kind of an old drug that's back. Indications, newly diagnosed CD33 positive AML, as well as relapse refractory CD33 positive AML, as well as acute promyelocytic leukemia in an off-label setting, although I think we've used this drug 3 times in the last several months up on Boy66, so we are getting more use of this agent. We've included kind of the dosing schema for Mylotarg. And again, hepatic dosing, we do have concerns quite a bit with that, and that was kind of the origin of it being pulled from market. So when you look at its black box warnings, we have severe hepatotoxicity and concern for potential VOD. This is kind of the biggest concern with these patients. We have found that in those who receive this agent prior to stem cell transplantation, there is a larger concern for VOD during the transplant-related process, as well as LFT abnormalities prior to transplant as well. Other adverse events, cardiotoxicity and fatigue, hemorrhage, and there are concerns, as we have mentioned previously, with immunosuppressants and live vaccines. Moving on, for time purposes, I kind of have 3 approved monoclonal antibodies for multiple myeloma, 2 of them targeting CD38. The biggest winner here is daratumumab. This is the agent that's really kind of taken over the myeloma space. Binding to CD38, inducing direct apoptosis via cross-linking, immune-mediated cytolysis via complement, as well as antibody-dependent cellular toxicity. Isatuximab also targets CD38. This is a relatively recent FDA approval, brand name Sarclisa, but it has not kind of reached the same prominence as daratumumab. And then we have elotuzumab, which targets a different receptor, SLAMF7, activating NK cells and mediates antibody-dependent cytotoxicity. Again, daratumumab is the big winner here. We're getting better at administration. This is a drug that does have significant infusional reactions, but we now have options. We split the first dose over several days to make it more tolerable. We have potentially sub-Q administration of this product. So we are getting kind of more clever, much like when Rituxan first came out. We've gotten better and better at administering it. We're learning how to better give daratumumab as well. I'm going to skip over dosing. You can refer to this if you'd like. We do have a lot of significant toxicities with these agents. Daratumumab, again, we talked a lot about its infusional interreactions, but interestingly, it does interfere with cross-matching and RBC antibody screening. So if anyone's received daratumumab relatively recently, they need to have specific antibody screening processes in place if they're to receive red blood cell transfusions. Isatuximab seems to have more count suppression than its daratumumab colleague, so you can see the numbers there on the slide. And elotuzumab seems to show more cardiac toxicity with an increased or decreased heart rate and blood pressure as compared to the other agents. All of these agents should be receiving pre-medications for infusional reactions with steroids, acetaminophen, and diphenhydramine. Polatuzumab, or Polivy, this is a recent approval targeting CD19. It does have a linker to an MMAE microtubule disrupting agent leading to cell cycle arrest. The FDA approved in relapsed or refractory DLBCL in combination with bendamustine and Rituxan. Well, I will say several of our patients who have received this agent here at UW, they have dropped the bendamustine and Rituxan and used this agent kind of in a single agent in those that are older or frailer. We have significant toxicities such as peripheral neuropathy, as well as count suppression and LFT abnormalities. Sacituzumab, brand name is Trodelvy, is an antibody drug conjugate against antitrophoblast cell surface antigen 2. This is metastatic refractory triple-negative breast cancer agent. You can see again our linker, cross-linker for our antibody, and we have significant toxicities including count suppression with severe neutropenia, and then as with most monoclonal antibodies, hypersensitivity reactions or infusional reactions can be seen. Enfortumab vedotin, brand name is Padcev, targets anti-Nectin-4 and has, again, a microtubule disruptor MMAE. Nectin-4 is highly expressed in urothelial, breast, gastric, and lung cancers, but its current only FDA approval is in locally advanced or metastatic urothelial. Significant toxicities including bone marrow suppression, large rate of skin rash and GI toxicities, but also ocular toxicities, not just dry eye syndrome, but actual scarring and corneation. And then peripheral neuropathy is relatively significant in this patient. It's an irritant, and extravasation reactions can be delayed up to a week plus post-infusion. So that is kind of a notable thing from your guys' perspective. Dinutuximab, probably the most interesting of all my monoclonal antibodies, is binding to GD2, inducing cell lysis via antibody-dependent cytotoxicity. This GD2 is highly expressed in neuroblastoma and most melanomas, but unfortunately it's also expressed in a lot of normal tissues such as neurons and nerve fibers. It's used in peds for high-risk neuroblastoma, and the dosing's there, and it's given in combination with sargramostim, IL-2, and isotretinoin. Requires significant pre-medications as well as treatment meds. In our treatment plans over at AFCH, Pre-medication includes Zofran, Tylenol, diphenhydramine, hydroxyzine. Patients receive a morphine PCA, including a strong basal, kind of at the onset. They receive lidocaine infusions, and they also receive gabapentin as an effort to try and minimize these neuropathic pains that can occur when you have this monoclonal antibody targeting neuroblastoma, but unfortunately hitting neurons and neuron fibers. Has black box infusion-related reactions, significant grade 3, 4 infusion-related reactions, 26%. Significant neurotoxicity, as we mentioned, pain in 85% of patients, capillary leak in 40% of patients, so real nasty stuff, but we're getting better at utilizing it as well. 2 more agents, I promise. Ionatuzumab ozogamicin, or Besponsa. This is a CD22 monoclonal antibody, which is conjugated to kalikiamycin, binding to the minor DNA group to induce double-strand cleavage. This is used in relapsed and refractory B-cell ALL. Dosing schema is on the slides. Pre-medication with steroids, antipyretics, and antihistamines. And this has a black box hepatotoxicity for delayed VOD during stem cell transplant, as well as a higher rate of post-transplant non-relapsed mortality in folks who has received ionatuzumab. So much like my CD33 agent previously, there is some considerations if these folks go on to stem cell transplantation. Bone marrow failure is actually seen in 2% of patients who receive ionatuzumab as well, so that's kind of significant. My last monoclonal antibody, my favorite, is a product called blinatumomab. It has a CD3 antibody and a CD19 antibody mushed together. These 2 monoclonal antibodies go in and bind to a cytotoxic T cell and bind to a cancer cell, bringing those 2 cells together closer, leading to T cell proliferation and the apoptosis of a cancer cell. So using this bispecific T cell engager, or BiTE, blinatumomab binds to the CD19 on B cells or malignant B cells, and CD3 expressed on those T cells, creating a cytolytic synapse. The dosing schema is on the slide. These patients receive 9 micrograms continuous infusion daily times 7 days. So this is a continuous drip of 9 micrograms per day. And then after 7 days, they're escalated to 28 micrograms a day thereafter. And the cell dosing, or the treatment schema, is 4 weeks on, 2 weeks off of continuous infusion blinatumomab. So logistically very difficult. Toxicities include life-threatening CRS in up to 15% of patients, neurotoxicity in 65% of patients, as well as arrhythmias, liver function issues, and this requires significant logistical considerations and hospitalization for dosing initiation and dosing ramping, requiring pre-medications for high-dose steroids and logistical issues. If they came into, we're really concerned if they go into like a local ER, the first thing that nurses usually do is flush a catheter that a patient may have. And if you flush this drug that's supposed to be 9 micrograms a day or 28 micrograms a day, and you flush that catheter over a short period of time, you can certainly trigger off things like life-threatening CRS very, very quickly. So logistically, this is a very difficult drug that is hopefully used as a bridge to a stem cell transplant and cure for these folks who have B-cell ALL. I'm sorry for going over a little bit today. We had a lot of monoclonal antibodies to cover, but feel free to reach out if you have any questions or concerns, and thank you very much for your time.